You are walking onto the med-surg floor, or, maybe the ICU, and you step into a patient's room.
And instantly the monitors are just screaming at you.
Right. The heart rate is flashing this bright red tachycardic 130. Your patient is sitting bolt upright, visibly struggling to pull in just a single good breath.
Oh, yeah. And when you look down, their legs are swollen so tight they look almost like tree trunks.
It is so intimidating. I mean, it is overwhelming. That right there is classic acute heart failure.
And honestly, that combination of aggressive monitor alarms and seeing visible respiratory distress, well, it can send a newer nurse's own heart rate right through the roof.
Oh, absolutely.
It's the stark reality of the bedside. It's where those textbook definitions suddenly become a very high-stakes physiological crisis happening right in front of you.
Well, welcome to this episode of the Super Nurse Podcast. Now, this episode is created by Brooke Wallace.
Yes, and for a little background, Brooke is a 20-year ICU nurse, an organ transplant coordinator, a clinical instructor, and, a published author.
Now, I am not Brooke Wallace, but we are using her extensive clinical experience, her bedside notes, and her signature teaching style today to help nursing students and new nurses bridge that massive gap.
Right, the gap between passing the NCLEX and actually keeping a patient safe.
Exactly. Because, memorizing pathophysiology for a multiple-choice exam is one thing. Standing in front of a patient who is actively drowning in their own fluids requires an entirely different level of clinical judgment.
It really does.
So if you want to master these concepts, please make sure to subscribe and watch the video version of this podcast on YouTube. The link is in the description. You can find us on the channel called Super Nurse AI.
You definitely want to check that out.
So we need to figure this out. The human body is incredibly complex, but heart failure management at the bedside really centers on two things. It's recognizing fluid overload and managing a dangerously low cardiac output.
Yeah, and by the end of this episode, when you see a patient gasping for air, you won't just hear the alarms. You'll understand the underlying mechanics.
Right. You'll know how to read the hidden clues in their lab work, and you will know exactly how to intervene.
So to understand those alarms, you have to look at the mechanics of the pump itself. The engine is failing.
Okay.
And the core metric of that engine is cardiac output.
Let's break cardiac output down into plain English. It is a very simple math equation, right? It's heart rate multiplied by stroke volume.
Exactly.
And stroke volume is just, the actual amount of blood the heart pushes out of the body with one single beat.
Yeah, and in heart failure, by definition, the heart muscle is failing to pump effectively. So that stroke volume drops significantly.
Okay, so less blood per beat.
Right. The heart simply isn't pushing out enough oxygenated blood to meet the metabolic demands of the organs.
And the body hates a lack of oxygen. It panics. The tissues send this emergency signal saying, we are starving down here.
They freak out.
But the body really only has one immediate split-second trick to try and fix the math equation, right? It speeds up the heart rate.
Which beautifully explains the presentation you see at the bedside.
Right.
The tachycardia isn't just some random symptom or a glitch in the electrical system. When you see that heart rate of 120 on the monitor,
it's the body desperately trying to maintain the overall cardiac output because the per beat stroke volume has completely tanked.
Exactly. It's compensating.
That connects the textbook directly to the monitor. But, not all pump failures are the same. Clinical experience shows us there are two main types, which are categorized by the ejection fraction, or EF.
Right. You have your HFrEF and your HFpEF.
Let's translate those. HFrEF stands for heart failure with reduced ejection fraction.
Yes.
This is your classic systolic heart failure. The ejection fraction is less than 40%.
And I think a lot of newer nurses struggle to visualize what that actually means structurally.
Well, I always visualize systolic heart failure as a squeezing problem. The ventricles have become dilated, thin, and incredibly weak.
Like they're just worn out.
Yeah, it's like trying to forcefully push water out of a floppy, overstretched water balloon. You squeeze it, but it just kind of bulges outward. It doesn't forcefully eject the fluid.
That is such a great way to picture the structural damage. The balloon is just too floppy.
Right.
But on the other end of the spectrum is HFpEF, which is heart failure with preserved ejection fraction. This is diastolic heart failure.
Okay.
Here, the ejection fraction is technically preserved. It's actually greater than 50%.
Now, I know this confuses so many nursing students. How can the patient be in severe heart failure if their ejection fraction is completely normal?
It's a great question. And the clinical evidence tells us that diastolic failure isn't a squeezing problem. It is a filling problem.
A filling problem.
Yes. The heart muscle has become thick, hypertrophied, and incredibly stiff. This often happens from years of pumping against high blood pressure.
So using a different visual, if systolic failure is a floppy water balloon, diastolic failure is like trying to fill up a rigid, calcified stress ball.
Oh, exactly. You can't get enough blood into the chamber in the first place.
So even if that stiff chamber manages to squeeze out 60% of what's inside, the total volume is so tiny that the body still starves for oxygen.
That's the key right there. And, normal ventricular filling actually relies on a very dynamic twisting and untwisting action. The mitral annulus physically moves up and down during the heartbeat.
Let's put that in plain English because the mechanics of that twist are fascinating. It's a lot like wringing out a thick, wet towel, right?
Yeah, that's a good way to look at it.
When you twist the towel, the water gets forced out. But the most crucial part is what happens when you let go. The towel actively springs open and untwists.
Which creates a vacuum effect.
Exactly. It creates a vacuum that would suck water back into the fabric. The normal human heart does the exact same thing. It untwists and creates a vacuum to actively suck blood into the left ventricle.
But in a stiff, fibrotic, diastolic heart, you lose that vital spring-like action. The vacuum just disappears, and blood cannot get pulled into the chamber efficiently.
Wow. So if the pump is either too floppy to push fluid forward or too stiff to pull fluid in, the blood isn't moving efficiently through this closed-loop plumbing system.
Right.
And if fluid isn't moving forward, it has absolutely no choice but to go backward.
And that backup is the primary cause of the fluid overload we assess at the bedside.
Makes total sense.
Differentiating where that backup is happening means understanding left-sided versus right-sided failure.
So let's trace the plumbing on the left side. The left ventricle is supposed to pump blood out to the entire body.
Right.
If it fails, the blood backs up into the pathway just behind it,
Yeah.
which goes straight into the lungs.
Yes. So the bedside signs of left-sided failure are deeply respiratory. You will assess dyspnea or severe shortness of breath.
You'll see orthopnea too, right?
Exactly, meaning the patient simply cannot pull in a breath when they lie flat. They might also report paroxysmal nocturnal dyspnea, where they wake up in the middle of the night completely gasping for air.
And when you put your stethoscope to the bases of their lungs, you are going to hear the physical consequence of that backup. You will hear wet crackles on auscultation.
Yeah, and that isn't just a sound. That is the acoustic evidence of fluid actively sitting in the alveolar spaces where oxygen exchange is supposed to happen.
They're literally drowning.
They are. Now, contrast that structural failure with the right side. The right ventricle is supposed to pump blood forward into the lungs.
Right.
If it fails, the blood backs up into the systemic venous system, so the rest of the body.
This is where you assess jugular vein distension, or JVD. You look at their neck with the head of the bed raised, and those veins are visibly bulging.
Yeah, you will also assess hepatomegaly.
Liver swelling.
Right, the liver gets so engorged with backed up blood that it swells, and a patient might complain of strange abdominal pain or severe nausea simply because their liver capsule is stretching.
And the hallmark sign of right-sided backup is peripheral edema. Gravity dictates where the fluid pools, which is usually in the lowest dependent areas, like the lower legs, ankles, and feet.
Experienced nurses know you have to listen carefully to the patient's casual complaints here. I mean, they usually won't use the word edema.
No, of course not. They'll say things like, my shoes just don't fit anymore.
Yes, or when I take my socks off in the evening, they leave these deep, painful indentations in my skin.
Right, because the gravity effect means the swelling gets progressively worse as they spend the day on their feet.
Now, the physical backup of fluid is devastating, but it also triggers a massive chemical cascade. Because the cardiac output is so low, there is significantly less blood flow reaching the kidneys.
And the kidneys are notoriously dramatic organs.
Very dramatic.
They sense that drop in blood pressure, and they panic. They don't realize the heart is failing. They just assume the body is bleeding out or severely dehydrated.
So what do? They activate the RAAS pathway, the renin-angiotensin-aldosterone system.
And the ultimate physiological goal of RAAS is to clamp down on the blood vessels and force the body to aggressively retain sodium and water.
Right, hoping to boost the blood volume and raise the blood pressure.
Okay, hold on. Let's look at the logic here. The heart is already failing because it cannot pump the volume of fluid it currently has. It is actively drowning.
Yeah.
Are you saying the kidneys activate RAAS to hold on to even more fluid and clamp the blood vessels tighter? Like, the body's own survival mechanism is actually sabotaging the heart.
That is the cruel, fatal irony of heart failure. The body's natural compensatory mechanism actively destroys the failing heart by drastically increasing the resistance it has to pump against.
while simultaneously drowning it in more volume,
Exactly.
which creates a massive problem for the nurse at the bedside. If the kidneys are actively flooding the system and a patient comes into the ER gasping for air with swollen legs, how do we prove it's this specific heart-kidney death spiral?
Right, because how do we know it isn't just a bad exacerbation of COPD or a severe case of pneumonia?
Right. So what do we do?
You look for the ultimate cardiac SOS signal, the BNP lab test.
Ah, the secret decoder ring for heart failure. B-type natriuretic peptide.
Yes. BNP is a highly specific hormone released directly by the ventricles of the heart. When the heart muscle is physically stretched out and distended by all that massive volume overload, the ventricular cells release BNP directly into the bloodstream.
It's the heart screaming for help.
Yes. The BNP circulates down to the kidneys and tries to force diuresis, meaning it tries to make the kidneys pee out all that excess fluid.
It also attempts to cause vasodilation, right? Like relaxing the blood vessels to take the intense pressure off the failing pump.
Exactly. But if the heart has its own built-in diuretic and vasodilator hormone, why doesn't it just fix the problem and cure the patient?
Well, it's like a sinking ship. The heart is down in the boiler room, using a tiny teacup, the BNP, to frantically bail out the water.
The teacup, I love that.
Meanwhile, the kidneys are up on the deck using the RAAS system to turn on industrial fire hoses, flooding the ship way faster than the heart could ever bail it out.
That is a perfect mechanical analogy. The RAAS system simply overpowers the BNP. The heart is trying its best to offload the fluid, but the kidneys force the body to retain it.
So we need to look at the actual lab numbers, because you will see these values every single day on a cardiac or med-surg unit.
Oh, constantly.
In a healthy patient without heart failure, the BNP is usually less than 100 picograms per milliliter.
Right. And if the lab value returns greater than 400 or 500, clinical evidence suggests heart failure is very likely the culprit behind the respiratory distress.
But the bedside reality, however, is often much more extreme. Patients showing up in the ER with acute decompensated heart failure often have BNP levels well over 1,000.
Oh, yeah. And if you are looking at an NT-proBNP test, those levels can reach over 5,000.
Wow.
Yeah, which carries a very high mortality risk during that specific hospital admission.
Interpreting those numbers requires real clinical judgment, though, because there are several critical bedside nuances. For instance, obese patients naturally present with significantly lower BNP levels, even if they're in severe heart failure.
Yeah, that one trips up a lot of new nurses.
Let's dig into why that happens. If their heart is failing and stretching, shouldn't their BNP be just as high?
It comes down to cellular receptors. Adipose tissue, so fat cells, have what are called natriuretic peptide clearance receptors.
Okay.
These receptors act like biological sponges. They actively bind to the BNP circulating in the blood and pull it out of the system to degrade it.
So a patient might be in severe fluid overload, but their adipose tissue is clearing the BNP hormone so rapidly that the final lab value looks artificially low.
Exactly.
That is wild. The fat cells are literally hiding the evidence of the heart failure.
They really are.
What about the patients with HFpEF, the ones with the stiff diastolic failure?
Well, they also tend to have lower BNP levels compared to the HFrEF patients.
Why is that?
Remember, BNP is released in response to the physical stretching of the ventricular wall. In diastolic failure, the wall is so incredibly thick, hypertrophied, and rigid that it experiences far less wall stress and stretch.
Ah, so less stretch means less hormone is released into the blood despite the severe failure.
Precisely.
There is also a major medication trap here that every nurse must know. It involves a very common heart failure drug called Entresto, which is a combination of sacubitril and valsartan.
Yes. The sacubitril component is a neprilysin inhibitor, and neprilysin is a natural enzyme in the human body that normally breaks down and clears away BNP.
Wait, so if you give a patient a drug that deliberately stops the body from breaking down BNP, their blood levels of BNP are going to absolutely skyrocket.
Exactly. But it's not because their heart failure is suddenly worse. It is a completely artificial elevation caused by the mechanism of the drug itself.
So if a patient is taking Entresto, ordering a standard BNP lab test is essentially useless for monitoring their acute fluid status.
It's completely useless. The nurse must use their clinical judgment, catch that medication in the chart, and ensure the provider orders an NT-proBNP test instead.
Because the NT-proBNP marker is cleaved off differently and is not affected by the sacubitril medication.
Right. That is exactly the kind of critical thinking that prevents massive diagnostic confusion during bedside rounds.
Okay, so we clearly see the fluid backup. We know how to decipher the BNP SOS signal. How does a nurse actually manage this profoundly decreased cardiac output during a demanding 12-hour shift?
It centers entirely on meticulously managing the cardiac workload. I mean, you are dealing with a failing engine. You cannot ask it to run a marathon.
Let's look at a classic new nurse scenario.
Yeah.
You have a highly motivated, organized nurse who wants to be super efficient.
We've all been there.
Right. They decide to cluster all their physical care at 8 o'clock in the morning. They give all the morning meds, do a full bed bath, completely change the heavy bed linens, and then physically assist the struggling patient out of bed and into the chair, all in one continuous 30-minute block.
Yeah, and for a healthy post-op patient, that is excellent time management. But for a heart failure patient, that sequence is physiologically disastrous.
Walk us through why that causes so much harm.
Well, every single one of those routine activities demands a sharp increase in cardiac output. The body requires more oxygenated blood to roll over in bed, to actively sit up, and to digest a handful of medications.
Right.
If you cluster all that physical demand into a tight window, a failing heart simply cannot increase its stroke volume to keep up.
So the patient will rapidly desaturate, become severely tachycardic, and completely exhaust whatever tiny cardiac reserve they had left.
Exactly. You must pace the client's activities. You assist with the bath, and then you intentionally let them rest for an hour. Then you change the linens.
You have to provide frequent, scheduled rest periods to protect that fragile cardiac output.
Improper positioning is another non-negotiable bedside intervention. If they are struggling to breathe, sit them up immediately.
Yes. Placing them in high Fowler's position drops their diaphragm downward and allows for maximum lung expansion.
You also have to be militant about intake and output. Your I&Os. You need a strict record of exactly how much fluid is going in and how much is coming out.
But even more critical than I&Os are the daily weights, right?
Yeah.
In heart failure management, weight is absolute gold.
Oh, it is the single most sensitive indicator of fluid retention we have at our disposal. 1 liter of retained fluid weighs exactly 1 kilogram, or about 2.2 pounds.
We educate these patients relentlessly before discharge about this. We tell them to weigh themselves every single day. Same scale, same time of day, usually first thing in the morning.
Yes. A sudden weight gain of more than 2.5 pounds overnight, or 5 pounds in a week, is a red alert emergency.
It means the RAAS system is winning. They are actively retaining fluid, and the backup is starting all over again.
Exactly. And alongside the daily weights, we have to manage the underlying physiology with medications. The clinical guidelines have evolved, and what we know from practice is the standard of care for HFrEF is now quadruple therapy.
4 distinct classes of medications working together. First, beta blockers to actively slow the heart rate down and decrease the engine's workload.
Right. Second, medications to relax the blood vessels and block that deadly RAAS system. These are your ACE inhibitors, ARBs, or ARNIs, like the Entresto we mentioned earlier.
Third, mineralocorticoid receptor antagonists, or MRAs, like spironolactone. These help block aldosterone, offloading fluid while sparing the potassium.
And fourth, the SGLT2 inhibitors.
Now let's dig into those SGLT2 inhibitors for a second, because medications like empagliflozin were originally developed as diabetes drugs.
Yeah, they were.
How did a diabetes medication become a fundamental pillar of quadruple therapy for heart failure?
The mechanism of action is brilliant. SGLT2 inhibitors work in the proximal tubule of the kidney to block the reabsorption of glucose and sodium.
Okay, so the sugar stays in the urine.
Right, and because water biologically follows sugar and salt, it causes a profound osmotic diuresis.
So they are peeing out the excess fluid. But why use this instead of just hitting them with more Lasix?
Because traditional loop diuretics like Lasix can inadvertently trigger the body's sympathetic nervous system. They can set off the exact panic alarms we discussed earlier.
So SGLT2 inhibitors manage to reduce the fluid volume and take the pressure off the heart without sounding those neurohormonal alarms.
Exactly. Furthermore, they actually improve myocardial energetics, shifting how the failing heart muscle utilizes energy on a cellular level.
It's essentially bailing the water out of the sinking ship without alerting the kidneys to turn the fire hoses back on.
That's a perfect way to put it. Plus, of course, we still use those heavy-hitting loop diuretics during acute exacerbations to rapidly pull the fluid out of the lungs.
We drill into patients the importance of quadruple therapy and daily weights. We give them strict instructions upon discharge to monitor their sodium intake and jump on the scale every morning.
We do.
But, stepping back for a second, we hand them this massive checklist. What if they don't have stable housing to store a scale?
Yeah.
What if they literally cannot afford a scale, let alone afford fresh groceries that aren't packed with cheap sodium preservatives?
You've just hit on the most critical shift in modern cardiovascular care. The newest guidelines now heavily incorporate the prevent risk calculator. And the clinical data reveals something deeply unsettling. A patient's ZIP code, their social deprivation index, and their housing stability are just as predictive of their lifetime heart failure risk as their clinical lab numbers or their blood pressure.
Wow. The environment is literally shaping the pathology. It forces you to realize that true nursing care, the kind that actually keeps patients alive and out of the intensive care unit, extends far, far beyond the four walls of the hospital.
It absolutely does. Summarizing the reality of the bedside, managing heart failure comes down to early recognition of fluid overload, listen to the lung bases for crackles, check the neck for JVD, and assess the ankles for edema.
And aggressively manage that decreased cardiac output by relentlessly reducing the heart's workload. Pace their physical activities. Never underestimate the clinical value of a strict daily weight.
And always look at the bigger picture of the patient's environment.
Well, if you found this breakdown helpful, please check out the video version of this episode on YouTube. Search for the channel Super Nurse AI, leave a like, hit subscribe, and drop a comment. You can also visit supernurse.ai for some incredible resources designed to help you become the super nurse you were born to be.
And as you head into your next shift, consider this. With the rapid rise of wearable technology and continuous hemodynamic monitoring, we are approaching an era where a smartwatch might detect a subtle drop in stroke volume days before the fluid ever backs up into the lungs.
Will the classic, terrifying presentation of acute heart failure eventually become a thing of the past? It's something to think about the next time you hear those monitors start to alarm.
Take care, everyone.